I do just want to run through what we found in the briefing that was published in December. And I've pulled out a few recommendations as well, which aren't actually in the report, but which I thought might be useful here. As Richard said, it was a project sponsored by the ABHI. And I'm just going to run through the brief and the approach that we took, what we found, some recommendations, and concluding thoughts. So ABHI approached us and asked us how the vision of creating a system in which the NHS is allowed to be a receptive market for useful innovations can be delivered. And we know there's been loads of reviews about what's wrong with innovation adoption in the NHS, and the Accelerated Access Review had a lot of reviews that also fed into it. So we really tried to start off with trying to understand what the Accelerated Access Review can deliver and where the gaps are. So to do that, we did a rapid review of the literature. We carried out 2 case studies, the esophageal Doppler monitor and the SCath suprapubic catheter, and we held a seminar with representatives from the NHS, industry and AHSNs. So we started with 3 simple questions, which is, why aren't all well-evidenced innovations adopted at scale? So, for example, the esophageal Doppler monitor has NICE guidance associated with it, which shows that it can have beneficial outcomes in a number of instances, but it still isn't used in those instances in many cases. Are the solutions proposed in the Accelerated Access Review enough to overcome the obstacles that we know exist? And what is needed to implement the Accelerated Access Review, including for national bodies like AHSNs and the new Innovation National Networks to fulfil the ambitions set out for them. So we had 8 findings. I'll run through these quickly, and then the recommendations draw on these later on. So we found that the solutions proposed in the Accelerated Access Review are strong and could go a long way to improve innovation adoption. So we broadly thought the Accelerated Access Review was a really good document, but it did leave some things unaddressed. Some people that we spoke to, though, felt that the Accelerated Access Review and the wider approach to innovation within the NHS is too supply-focused. So, i.e., it starts with products first and thinks about how they could be implemented rather than helping the NHS identify what its most pressing problems are and then think about what solutions could address them. It's often unclear who should be responsible for innovation. I'll come on to this later on, but there's divergence about how far chief execs should be involved in the process, for example. Adaptation is just as important as adoption. So we know that for system transformation, patient pathways and things like that are going to have to change. And that can be very difficult. Evidence needs to be generated and applied differently. So again, I'll come on to this in a bit more detail a bit later. But at the moment, the gold standard is RCTs, and that tension between robust evidence and being cutting edge with new innovations is difficult to address. System barriers play a really significant role. That might seem really obvious, but culture is always sort of given as a reason for lack of innovation in the NHS. So the lack of an entrepreneurial spirit is often talked about. Clinicians are stuck in their ways. They've done things a certain way for a long time and they don't want to change. These are things that you hear time and again. But actually, it seems that the system is likely to play possibly even a more important role. And that includes things like lack of clinician time to even think about what the most pressing problems are and how solutions can address them. The fact that procurement departments are often judged on short-term cash-releasing savings rather than long-term transformation, which is likely to deliver greater efficiencies in the longer term. And also the fact that tariff often doesn't keep pace with the latest innovations. So in many cases, you're better off to be sort of a second or third generation adopter rather than an early adopter. We found SMEs aren't doing a lot wrong, although there are opportunities they could better exploit. So that includes focusing on growing the entire market for their product rather than just focusing on their market share, particularly where you're talking about there being sort of 2 or 3 SMEs dominating a particular clinical area. And if they're warring with each other, it's often counterproductive, and it means that clinicians don't want to engage with them often. And we also found that NHS should consolidate existing policy before introducing new policy. And again, I'll come on to that a bit later on. So, the first recommendation that I've pulled out is that we should devote more resource to innovation, uptake and spread. So, an AHSN review, I think it was the Innovation Health Network in South London, found that the private sector typically spends 2.5 to 3 times more on dissemination than development. And in the NHS, as you all know, it's the reverse. So R&D budget is around 1.2 billion through the NHR, and it's about 50 million budget on spread and uptake. So there's a massive difference there. The government's committed 86 million in response to the Accelerated Access Review, which is great, but it falls significantly short of what the Accelerated Access Review recommended in terms of funding, and particularly in terms of the recurrent funding for AHSN baselines. So therefore it's going to be quite difficult, it seems, for AHSNs to take on the change management role that's envisaged for them, particularly because there's a massive difference between the resource and the sort of the networks and capacity that AHSNs already have. So because, I'm sure you're all already very familiar with this, but because the remit of AHSNs was so broad when they were established, some have focused on innovation, adoption from the outset, others have focused more on sort of the research and development side, and it means that some have really good networks to be able to implement at scale and to be able to connect in with the NHS, but others don't. And so it's not just a question of resource, it's also a matter of time and energy to be able to build up those networks and build up that infrastructure to play that role. Recommendation 2 is to not lose sight of the problems that need solving. So, as I said, there's a concern that things are too supply-focused at the moment. We're not starting with what the biggest problems are. The Accelerated Access Review acknowledged this, and it proposed the establishment of the Accelerated Access Partnership, which it proposed would have the remit of helping the NHS articulate to innovators the technology requirements that would best support its needs. In the government response to the Accelerated Access Review, they set out this would be realised as the Accelerated Access Collaborative. And though that response was brief, it seemed to be suggesting that it would help identify products for the accelerated access pathway, and that would be its main remit, as opposed to focusing on problems that need solving. I've since been assured that the government hasn't lost sight of the need to identify problems, but it's still a little bit unclear exactly how that's going to happen and how the Accelerated Access Collaborative will play out. So I think that's something to watch out for and something that we should all be sort of paying attention to in terms of how the AAC fulfills its role. So as I said, it's often not clear who should be responsible for innovation. It's often not embedded into routine processes. It's often seen as a luxury that should only be attempted when things are going well. And as I said, there's divergence on how far CEOs should be involved. Some felt that it really wasn't the role of a CEO to be getting involved with innovation decisions and that they should be focusing on much higher level strategic things. But when patient pathways need to change, when big transformation is needed, when, for example, an innovation allows a nurse to do something that would otherwise require a consultant, there are really big changes that have to be signed off by somebody with board oversight. And that means that it's unclear at what point the chief exec should get involved and when that should happen. So we've suggested it should be written into job descriptions, either the chief executive's job description or something that's happening in the private sector is chief innovation officers whose sole job is to look for problems and to neatly define what the problems are and think about how innovative solutions could help address them. The fourth recommendation was to think about evidence differently. So as I said, there'll always be a tension between making sure there's a very robust, well thought through evidence base for a particular innovation and being at the cutting edge, being able to implement things that are fresh to market. Again, the Accelerated Access Review acknowledges this and suggests new ways to test innovations locally, so the Accelerated Access Pathway, which will sort of be used to test innovations in a real-world setting, which is a really good idea. But the main problem, it seems, is not actually how good the evidence is in practice. It's how the evidence is actually perceived. So the NIHR prioritises funding randomised controlled trials. Academics are rewarded for academic publications in high-quality journals. And therefore, randomised controlled trials are always seen as the gold standard of evidence, and anything beneath that is often viewed with suspicion, and clinicians aren't necessarily always sure how to interpret it. So one thing that needs to happen is that people need to become a bit more open-minded about different types of evidence and to understand how they should be interpreted based on how that evidence has been generated. And finally, we suggest not introducing new policy before consolidating what we already have. The Accelerated Access Review suggested an awful lot, most of which has been accepted by the government. And I think we need to kind of get those bodies sort of off the ground and up and running. But we did find that because there's so many sort of different bodies out there, there's the AHSNs, there's NICE, there's the clinical research networks, there's the new INNs, there's so many acronyms that industry and SMEs find it very, very difficult to know who they should be approaching, to understand which body is playing which role. So we thought there's a very big opportunity for the centre to articulate that very clearly and to give industry and SMEs a bit more support in actually navigating their way through the NHS. And obviously AHSN's doing a great job of that at the moment, but I think there's more to be done in terms of understanding the broader landscape. So concluding thoughts. There remain fundamental obstacles to innovation adoption that are not addressed by the Accelerated Access Review or the government response. And perhaps the most pressing of those is the fact that we still seem to be focused on products and the supply side. And things like the ITT, the Innovation and Technology Tariff, only sort of exacerbate that problem. The government has not fully financed the Accelerated Access Review recommendations, and it's probably overlooked important aspects. We also know from past experience that standard policy instruments have had very limited impact on encouraging innovation adoption to date. For example, Innovation, Health and Wealth was largely not as successful as it could have been. It relied on sequins, it relied on financial incentives, and these things just weren't productive in getting the NHS to take on new innovations. So supportive bodies like AHSNs and INNs will have to play a very big role in sort of change management, holding the hands of both industry and the NHS to make that change.